Hello. So today we are going to see the interpretation of liver function tests in short. So first thing that we have to do is to localize the problem area. So we have to look which of the tests are abnormal. So if we see that the SGOT, SGPT and the serum proteins, that is the albumin and globulin levels are abnormal, then the problem lies in the liver cells. Whereas if there is an abnormality in the direct bilirubin, ALP or the GGT, then the problem lies in the biliary tree. Whereas total bilirubin may be increased in any of the conditions affecting the liver, which may be hepatic conditions or extrahepatic conditions. So total bilirubin levels are a bit of a non-specific marker. So the second thing that you need to do is look at the protein levels. The two main proteins produced by the liver are albumin and globulin. So the normal albumin levels are approximately 3.5 to 5.5. And since albumin is a negative acute phase reactant, the albumin levels are not affected in acute conditions. So a decrease in albumin would suggest that the condition affecting the liver is a chronic condition. And the most common causes of hypoalbuminemia are cirrhosis, nephrosis and gastrosis. Gastrosis is mainly the protein losing enteropathy, and nephrosis is mainly the nephrotic syndrome wherein the proteins are lost in urine. And also there is no condition in the body wherein the albumin levels are decreased. So a rise in total protein levels will suggest that the globulin levels are increased. Globulins are basically the immunoglobulins or the antibodies, and the increased globulin levels are mainly caused by sepsis, chronic viral hepatitis, HIV infection and a malignant condition called multiple myeloma. Once you are done with this, the third thing that you have to do is look at the bilirubin levels. Normally they are up to like around 1.2, and amongst this the direct bilirubin is 0 to 0.3 and indirect bilirubin levels are 0.2 to 0.9. So an increase in direct bilirubin levels, which is the conjugated bilirubin, would suggest an obstructive jaundice, whereas an increase in indirect bilirubin will suggest a hemolytic or prehepatic jaundice. So once there is a rise in total bilirubin levels, you have to see the distribution. So if the more than 15% of it is the direct bilirubin, then the possible causes are Dubin-Johnson syndrome and Rota syndrome. Whereas if less than 15% of it is direct bilirubin, then you have to look for hemolysis. Then for hemolysis you can do the tests such as heptoglobin levels, LDH levels or peripheral smear. If you see that hemolysis is present, then find out like which hemolytic disorder is causing it. If the markers of hemolysis are not present, then you have to check the drug history and look for usage of drugs such as rifampicin or probenecid. And if the drug history is also negative, then the possible causes would be Crigler-Najjar syndrome or Gilbert syndrome. And now comes the fourth step, which are the enzymes, which is SGOT and SGPT. SGOT is also called AST and SGPT is also called ALT. The way to remember this is that L stands for liver, so ALT is specific to liver, whereas AST is also found in muscles such as cardiac muscles and skeletal muscles. So for practical purposes, a rise of up to around 150, or that is 5 times the normal levels, is considered to be a chronic causation, whereas a rise of about like more than 1000 is said to be seen in acute conditions. So first let us see the conditions which cause a rise in SGPT levels more than SGOT levels. SGPT is ALT, which is liver specific. So chronic conditions which cause a rise in the enzymes like up to 150 include viral hepatitis, autoimmune hepatitis and Wilson's disease, and also hemochromatosis. And extrahepatic causes which cause increase in mainly the SGPT levels include celiac disease and hyperthyroidism. Whereas acute increase in the SGPT and SGOT levels, mainly the SGPT levels to more than 1000, can be caused by acute viral hepatitis, autoimmune hepatitis, Wilson's disease again, drugs and toxins, acute Budd-Chiari syndrome or acute biliary obstruction. And now let us see the conditions which mainly increase the SGOT levels, which is non-liver specific. So chronic conditions include alcoholic liver disease. Uh, in this case, in case of alcoholic liver disease, the SGOT to SGPT ratio increases to more than 2:1. Other extrahepatic causes are hypothyroidism and strenuous exercise. Similarly, the acute causes which cause an increase of more than 1000 include the use of drugs such as paracetamol in a patient with pre-existing ALD or alcoholic liver disease, and the most common extrahepatic cause for increase in SGOT is rhabdomyolysis. Lastly, we have to see the alkaline phosphatase levels. Normally it is 4 to 140. For practical purposes, up to 4 times the normal value can be seen due to physiological causes like pregnancy, heavy meals, or people having O positive blood groups, adolescents, and in elderly. So an abnormal increase of more than 4 times the normal is considered to be pathological. So although the ALP is not specific to liver, as it is also seen in bone diseases like Paget's disease of the bone, we have to also see the GGT levels to rule out the other extrahepatic causes, as GGT is specific to liver. So after that we have to do an ultrasound. So if we see dilatation of the intrahepatic ducts on ultrasound, it means that there is presence of extrahepatic biliary obstruction, and this can be caused due to mainly stones, malignancy, or infection. And if the ultrasound is normal, then it suggests that the obstruction lies within the liver, that is intrahepatic biliary obstruction. And the most common causes of this condition are primary biliary cirrhosis, primary sclerosing cholangitis, sarcoidosis, and the drugs. Finally, we will see some basic management of liver diseases. So in case of an acute liver failure, we mainly have to give supportive treatment. In acute liver failure, there will be hypoglycemia and hyponatremia. So we have to correct these conditions. In case of gallstones, we can give the UDHEP tablet 300 milligrams HS for 6 months. And in case of cholestasis, which is apparent by the presence of pruritus, we can use calamine lotion topically, and also we can give tablet cholestyramine 4 grams 3 times a day. And in case of ascites, we have to first restrict the fluid and the salt, and then we can start the 2 drugs, which are spironolactone and furosemide. The starting dose can be 100 milligrams and 40 milligrams respectively, and this can be increased gradually up to 400 milligrams of spironolactone and 160 milligrams of furosemide. In case of acute hepatitis A and hepatitis E infection, one has to stop alcohol and spicy food for 1 year, and in case of severe nausea and vomiting, we can administer injectable vitamin C, vitamin B complex, glucose, and ondansetron. The dose of ondansetron can be 8 milligrams for this condition. Now finally, to sum it up, let us look at the most common causes of acute liver failure. First one is the viral hepatitis, then comes the drugs. Some of these drugs cause dose-dependent hepatitis, such as paracetamol, calcium channel blockers, and mushrooms, whereas dose-independent hepatitis can be caused by isoniazid, phenytoin, and nitrofurantoin. Then are the toxins, then Budd-Chiari syndrome, autoimmune hepatitis, and lastly there is the acute fatty liver of pregnancy.